hello again, my fellow radiology geeks of the internet, and welcome to the next installment in our series on the normal radiographic anatomy lecture series. Today is lecture number 2, and we will be going through the normal appearance of the forearm, elbow, and humerus. Just to reiterate from the last lecture, if you've been following us in this series, last week I went through the normal appearance of the hand and wrist, and I just want to reiterate to you guys the reason why you should be following this series is because the game of radiology is basically playing a massive game of spot difference. So in order for you to really and truly master and be successful in the field of radiology, you must have a fantastic memory bank of what the normal appearance of each area of anatomy should look like to make abnormalities such as fractures, dislocations, soft tissue findings and signs, and other serious pathologies such as cancer or infection will all jump out to you like a sore thumb. So if you are enjoying this lecture series, please feel free to like and subscribe to the channel. It will be very much appreciated if you could do that for me. It just helps get this information out there to as many radiology students as possible. So today, like I say, we're going to go through the forearm first of all, because we did the hand and wrist last time, so it makes perfect sense that we're going to work our way up the upper extremity. So we'll do forearm first. Just a little note that most of the time forearm and humeral projections they're most commonly obtained as a result of trauma. So for trauma evaluation, so you've got somebody who's fallen onto an outstretched arm or outstretched hand, so a good old foosh injury, or you've got a FOD, fallen over whilst drunk injury. So yeah, most of the time they're not the typical projections you're going to see in everyday clinical practice necessarily, unless you work in A&E departments and things where you'll do them all day long. So standard series for forearms are they're taken A to P, so and lateral are the most common X-rays to be taken. AP forearm is obviously standard projection. It's best for analysing the overall anatomy of both the ulna and radius, and you'll also include the elbow and the wrist. In this, obviously, the projection should also include the distal humerus, the entire radius and ulna, and also you'll get the carpals in there. The reason why for the students out there that are learning this for the first time, when you have a patient who's had a foosh injury or a fallen over while drunk injury, the radius and the ulna effectively create a ring of bone. Well, I'll show you in a moment what I mean. But because you've got two bones that articulate both at the proximal end and the distal end, if you've got somebody who's fallen over onto an outstretched hand, obviously they will either fracture the carpals or the wrist, as we the distal aspects of the forearm, as we spoke about in the last lecture. But what can also commonly occur as well is if you've got a fracture of the distal end, then it's important that you have an image of the proximal end as well, because if you've got an injury at one end, you can very easily injure the other all at the same time. It's all through the same mechanism of injury. The forces applied to the distal end will also affect the proximal end. So the evaluation of the entire forearm, including the distal humerus, because you can have supracondylar fractures of the humerus, obviously the distal humerus, the elbow end, or you can have fracture and dislocation of the radial head, the olecranon, things like this, of the ulna. So this is why this is a very common projection that's done in A&E. And then if you've got so with that mechanism of injury, just to be able to rule out injuries at both ends, and then if you find an injury at either end, you'll then do a hand and wrist, or you'll do an elbow to fully assess the main injured sites, whether that's the wrist, the elbow, or both. So the patient's hand is usually in supination for a standard AP forearm. However, it can be obtained in pronation. The only real difference is that the proximal radius and ulna will overlap during pronation, which can sometimes obscure the radial head, the parts of the proximal ulna, and also the radial tuberosity may be obscured. Central ray is at the midpoint of the full length of the radius and ulna. Okay, so just here, approximate midpoint is where the central ray will be along the length of the ulna and radius, and you will also include, like I said, the carpals, and you will also include the elbow, all in the same image. So if you've got a patient who has had an injury of fallen on an outstretched hand, you'll be able to potentially catch a fracture of the carpals or distal ulnar and radius, or you'll get, you'll also see the proximal, you'll also see the shaft, you'll also see the elbow. So it's really, really helpful for you to know for that mechanism of injury. And this is what it will look like. So let's go through labelling the anatomy. So obviously we have the distal humerus, we have the radius, we have the ulna, and we have the carpals. Okay. The important thing to remember with this is obviously the radial head is the giveaway for when you're first learning this for the first time, that this is the radius, because of the, obviously it's a very, very distinctive flat topped bone that allows for very, very helpful rotation during pronation and supination of the wrist, because ultimately it happens at both ends. So the radius has the very distinctive flat top to it, and it articulates with the capitulum of the distal humerus. Again, going through in a little bit more detail. So you've got the radial head, you've got the radial tuberosity, which is this rather distinctive bump in the proximal shaft of the radius. Then you've got the coronoid process of the ulna. Then of course you've got to remember that there is the interosseous membrane traversing the gap between the two bones in the mid shaft. And then you've got the syndesmosis of the distal end of the radius and ulna. So don't forget that obviously this is still a joint at this end, as we went through last time. This is a PEDS case. Okay, so this is just to show you the difference between an adult and a pediatric case. I will take you through some PEDS today as well, just so that you've got a full understanding of everything that goes on, and obviously you can understand exactly what we're dealing with when you start getting into PEDS. If you start going down the road of PEDS, it is incredibly difficult area, real specialism. So it's fascinating to see, and it's always very, very handy to know, but it can become very daunting when you start getting into PEDS trauma in particular. So of course we've got the distal humerus. Oh my god. Well, that's clearly not the radius, that's the ulna. That's the radius on this side. I'm going to leave that in. That's just terrible animations by me just there. But I'm going to leave that in. I think that's great. We also have the carpals, as we went through last time in the last lecture series. This particular patient has two carpals. The capitates is the largest and the first one to form, and then of course in this particular picture we've got two, so this child is going to be approximately 2 years old. This is the ossification centre of the capitulum. Notice how when it first starts to form it looks as though it is nowhere near the distal humerus, but that is where it starts to form, and there is a specific sequence at which they will form, same as the carpals, so we'll go through that at the end of this lecture as well as a little pearl for you guys. And then this is the ossification centre of the distal radius as well. It will start to form at the other end. You can of course therefore get fractures, and you'll get avulsion fractures of the capitulum and of the ossification centre of the distal radius. So just to keep that in mind when you're going through your trauma cases. So lateral projection, again, standard view. You need to be taking both AP and laterals as a standard with most areas of anatomy to make sure that you're covering it in two planes. So it's great for evaluating the overall anatomy. There is a note here to notice that if you note the curved shape of the radius, this is something that this view particularly appreciates. So it's very, very helpful. It should also include again the distal humerus and the entire radius and ulna, and of course the carpals. Because you're including the carpals, if you're getting the true lateral, you will get the rubber duck sign that we spoke about in the last lecture series. So that superimposition of the carpals should obviously be present as well. You will also be able to see the anterior fat pad or the pronator quadratus fat pad at the distal end of the radius, and the central ray again will be at the mid-length of the forearm. So this is roughly what you're aiming for. Again, this would obviously include the carpals and the wrist. Then you've got the entire forearm, and then of course you've got the elbow and the distal humerus at the other end. And so this is what it should look like. Of course, starting at the distal end, here's your rubber duck sign again. So even with the divergence of the X-ray beam for a lateral forearm, you will still get that superimposition. But of course, you can see how the duck's neck is really long. So as a result of the divergence of the beam, this end and this end will be quite distorted because the X-ray central ray is somewhere obviously in the midpoint. So this is the true representation. These are distorted at either end. So the rubber duck looks as though he's got a really, really big neck on this particular projection. And again, if you notice the curve of the radius just here is something that's not really appreciated in any other view. Very, very interesting to see that. In comparison, the ulnar will look particularly straight. However, obviously, as we go up towards where the coronoid process is on the anterior surface, obviously we've got a large bend in the bone just there as well. So let's start labelling it again. So we've got obviously the distal humerus, we've got the olecranon, we've got the radial head. That's obviously therefore the ulnar and the radius. I'm glad they were animated together this time. And of course you've got the carpals, and you can also see the pronator quadratus fat pad in the distal aspect of the radius. And again, this is what it looks like on a PEDS case. Starting at the other end, we've got the carpals, then we've got the ossification centre of the distal radius, then we've got the ulnar, the olecranon, and of course the radius, radial head, and distal humerus. What I haven't labelled is this little bit just here, which, as we should be remembering, as we just spoke about, this is obviously the ossification centre of the capitulum, of the distal end of the humerus. Again, the big thing that people tend to first notice is with the elbow, how obviously on an X-ray, because of all the cartilage not showing up on the X-ray because of its low density, they look as though the articular surfaces are nowhere near each other, which is always, again, it's always really daunting because obviously dislocations of this area do happen, and so being able to notice when something is normal and abnormal becomes much, much more difficult to do. So let's jump into an elbow X-ray series. Standard images are again AP, lateral, and of course you do have an oblique as well, which is actually really quite difficult to do, especially it's difficult for the patient to do. Let's put it that way. It's not difficult for you to do. It's difficult for the patient to do because most of the time you're going to do an oblique view as a result of a trauma, which usually means that the patient's going to have limited range of motion, and so getting them to do the oblique view can be really challenging, very difficult to do. So take your time, guys, if you're going to set patients up to do this particular view. So starting with the AP, again, best for viewing overall anatomy as always. Can be taken with supination or pronation, but usually taken in supination because it aids in the evaluation of the radial head and proximal radio-ulnar articular surfaces. Central ray is the midpoint between the humeral epicondyles. Okay, so this is what it should look like. I apologise for the low quality of the picture just here, but you've got the medial epicondyle, which is visible just here with this obviously a little bit of a bulge on the outside. So of course lateral epicondyle somewhere over here. So midpoint between the two, you should see, you should better get the midpoint central ray, which will go straight through the joint. And it should look something like this. So here is obviously a standard AP. This is obviously a right elbow. And again, just going through the anatomy real quick. So we've got obviously the distal humerus, we've got the lateral epicondyle, we've got the medial epicondyle of the distal humerus, we've got the proximal ulnar, and we've got the proximal radius. Going into a little bit more detail, guys, we've got the capitulum, which is the articular surface with the radial head. Okay, so the way to try and to remember this is the lateral aspect, where the radius is where. So we've got the lateral epicondyle, and then the capitulum, where the radius articulates with the distal humerus. Then we've got the radial tuberosity, which again you can see when you see it on on an elbow view, you notice just how large it is. When you see it on the forearm, it doesn't actually look all that big, but you can really appreciate just how large this particular area of bone. This is obviously the attachment site for the biceps tendon and things like this. Then you've got the coronoid process of the ulna, which is here, just here. It is obviously on the lateral view. It looks a lot more. It's a lot more easy to see. And this is obviously quite a large bony projection, which again is area of muscle attachment, and it will slot straight into the fossae on the distal humerus. Then you've got the trochlea, which is the articular surface between the distal humerus and the proximal ulna. Then you've got the olecranon, which is obviously back here, just here. This is superimposed by the distal humerus, which is obviously making it very difficult to see. However, its location is important for when you're reviewing normal anatomy, because ultimately it needs to be able to articulate with the both the trochlea, but also the olecranon will slot into the olecranon fossa. So up here we've got the superimposition, this dark area just here, kind of looks like a bowl if you hallucinate it for a moment. This is where both the coronoid fossa on the anterior surface and the olecranon fossa on the posterior surface obviously overlap with each other, so therefore obviously it looks quite, the density drops quite a bit, because this is quite a narrow area of bone, and that's something that's really, really easily appreciated on the lateral view, which we'll go through in a sec. This is a PEDS case where we have, again, distal humerus. We've got the medial epicondyle, we've got the olecranon and the ulna, then of course we've got the radius and the ossification of the radial head, and of course therefore that is the ossification centre of the capitulum, and then we've got the lateral epicondyle around the outside, just here. I didn't label this one because, again, I want you to be able to appreciate that when you're viewing this for the first time on a PEDS case, it is really difficult sometimes to get your head around the fact that they don't look as though they articulate with each other at all. They look as though they are nowhere near each other. So how you assess the approximation between the olecranon and of course the olecranon fossa becomes a lot more challenging when you're doing PEDS cases. There are certain measurements, angles that you can take around here to make it a lot easier for you. I'm not going to go through them in this particular lecture, because this is the normal appearance of this area of anatomy. When you go through your trauma cases, that will be when you need to know the measurements and the lines and angles that you need to measure. So I'm not going to go through that with you in the normal series. Then we've got the lateral elbow, great for evaluation of the radial head, the coronoid process, the olecranon process, and for the soft tissue signs of occult fracture of the distal humerus and radial head. These signs are usually things, so these are most commonly known as the Sale sign, where you can see the anterior and posterior fat pads that are present at the distal humerus. They are only visible in signs of trauma. So even if you can't see the fracture line itself, if you can see the posterior fat pad sign or you can see the anterior fat pad sign, you know there is a fracture present, and it's most likely going to be of the distal humerus or the radial head, at which point the patient needs to refer it out for further imaging. This is taken with 90 degrees of elbow flexion. Must get superimposition of the humeral condyles, and I'll show you why in a second. And the central ray is over the crease of the elbow. So again, elbow is at 90 degrees of flexion, crease of the elbow. I've centered this slightly high, but obviously this is my elbow, so it doesn't really matter. It's just an example of how you would take it. Just to point this out as well, when you've got 90 degrees of flexion, you've also got 90 degrees of external rotation of the patient's wrist, so the patient is in a supinated position when you take this image, and that's to help with the overlap and superimposition of the radial head. Okay, so just so you know why. Epicondyles and condyles of the distal humerus, they will make up what appears to be this nice circular shape just here. You can see where the olecranon fossa comes in and the coronoid fossa come in as well. So the reason why you can see this area of density, this cortex just here, is because technically the fossae are here and here, where the coronoid process comes up and in, and where the olecranon process comes up and in. So you can just about make out the curves of the distal humerus that allow that articulation to occur. So labeling the anatomy again, we've got the distal humerus, we've got the coronoid fossa, we've got the radial head, we've got the olecranon fossa, we've got the olecranon process. The trochlear notch is basically the entire surface just here. Because we know that the proximal ulna articulates with the trochlea, the radial head is articulating with the capitulum, which is just here. So once you really understand the anatomy, it becomes much more easily for you to identify these structures. This is again a PEDS case where again I just want you to be able to appreciate the fact that the elbow doesn't actually look as though it articulates with each other. This is the ossification center of the capitulum just here. You can just about see the radial head ossification center as well, and of course the trochlear notch is not present, so the trochlea is not developed in this child just yet, and we will go through the acronym of how you remember the ossification centers of the pediatric elbow at the end of this session. So the oblique over, as I say, is very difficult or challenging for the patient to be able to do this. The setup is exactly the same as the AP view, however you have basically an over supination of the wrist. This is to allow you to bring both the radial tuberosity into profile, and also for assessment and clear visualization of the proximal radial ulnar articular surfaces. You can support the patient's forearm with a triangular wedge in this position, especially if you're able, or if you have a setup, or if you're in A&E departments and things like this, where you have full freedom, where you can have the patient in a seated position with an arm resting on a table or a surface with the cassette under the elbow. You can ask them to externally rotate or over supinate the arm the wrist as far as possible, keeping the elbow straight, and you can then put a triangular wedge just underneath the forearm to help support them in that position. And this is what it would look like. Again, the only real difference here is the simple fact that you've brought the radial tuberosity away from the ulna, sort of bringing it a bit more into profile, so you can appreciate that a bit better, and you can see the articular surface between the proximal radius and ulna, so you can really see that joint line nice and easily on this particular projection. So this is not particularly a standard view, but you can also do what they call the acute flexion position, where this is mainly to evaluate the olecranon process, but also the ulnar groove, or the ulnar nerve groove, or the of the distal humerus. It's obtained with the patient with full flexion of the elbow. It can be obtained with a mild amount of external rotation of the shoulder, which sort of brings the ulnar groove, the ulnar nerve groove, into a slightly better position and visualization. So this is how you set the patient up again. Just so in this particular setting, obviously we've got the cassette underneath the patient's elbow. They're obviously in a seated position, and if they can, we flex the elbow as far as possible. Central ray is probably going to be a little bit more over here, but this is a nice generous view for us to be able to see as much of the anatomy as possible. And this is what it will look like. So just so that we are able to orientate ourselves. Number 3 is the medial epicondyle. Number 6 is the lateral epicondyle of the humerus. This is the olecranon process. This is the epicondyle groove where the ulnar nerve sits. You have the trochlea just here as well. Number 5 is the olecranon fossa. So when the elbow is straight, the olecranon will slide into this nice little triangular dome-shaped fossa just here. You can really see the joint line really nicely in this particular image as well. So it's very helpful for that. This is again a slightly unusual image. It's not a standard view in most A&E departments. However, it is available to you should you need it. So jumping into the humerus, obviously we're working on our way up the arm towards the shoulder. So next week's or the next one next in the series is going to be obviously shoulder. Just to just to try and give some kind of structure to how we're going to learn these things. There's two main views. The obviously taken AP and the lateral, which is technically taken at a P'd away. It's a slightly unusual image to take when you first see it, but I'll explain it to you as we go through. The AP projection, again used to assess overall anatomy. Should include the shoulder joint. You should also be able to see this parts of the scapula, if not all of it, and you will also be able to see the elbow. Again, same reason as to why you would take the forearm view and include obviously the distal and proximal ends of the forearm. So you've obviously got the elbow and the wrist included, is because of the mechanism of injury. If you've got a patient who has fallen onto an outstretched arm, you can have you can have fractures and dislocations of either end. So you can, for example, decent high force onto an outstretched arm, as the forearm stops, if the person's body obviously keeps going, the elbow can fracture at the distal humerus in a supracondylar fracture, and at the same time you may have a dislocation of the shoulder as well. Central ray for this particular image is the midpoint of the length of the humerus. So just here, again, the image will include up here the proximal humerus with the humeral head, the glenohumeral joint, and most likely most of the scapula, and you'll also get the elbow in on the same image. And this is what it will look like. Just labelling the anatomy, you can see the distal clavicle and the AC joint, the acromial clavicular joint, just there. So of course we've got the acromion, we've obviously got the scapula and the radial head. You can also see the entire shaft of the humerus and of course the elbow joint at the far end. This is a Pete's case. Again, I just wanted to show you this one because, again, when you're looking at the different ossification centres, this one we can see the medial epicondyle is starting to form as well. Radial head has gone quite a long way, as has the capitulum. So this is going to be a slightly older Pete's case than we've gone through so far. And up here we've got the growth centre, the epiphysis of the humeral head with its growth plate still visible. You've also got the superimposition of both sides of the humeral head, which would conform what is often described as a pseudocyst. This looks very, very similar to the appearance of a simple bone cyst just there, so all of my students who have recently gone through benign tumours will know to be a bit more concerned about that. We've obviously got the distal clavicle and of course the rest of the scapula, and on this particular image we can also see some ribs. So the lateral humerus, this is taken in basically the same setup as the AP, but it's effectively taken as a P'd away. So the patient is facing the bucky, and usually the elbow is flexed with a hand on hip type of position, just to bring the shoulder and the arm away from the body, just making it much easier for you to be able to get the image that you're after. So if the patient is capable of mild amounts of abduction of the shoulder, so if they haven't fractured or dislocated the humerus at the proximal end, then you'll be able to get the patient to do this one. And this is what I mean. So technically, as you see it, the patient is facing the bucky, just here, and instead of asking the patient to be able to rotate the arm around so you can get a decent lateral view, basically you take it from a P'd away position, but with the hand on the hip type of presentation, you're obviously looking more towards where the biceps and where the triceps are. So the central point is right between those two. That's where the humerus will be, and of course you've got the you'll have the elbow and of course the shoulder joint all included in the same image. So this is what it should look like. Just to point it out for you as well. So the more acutely aware clinicians and obviously students out there, the image that I showed you, the patient here, which is obviously me, has got flexion of the elbow here, flexion of the elbow, but it's moving away from the chest. So this is actually an externally rotated shoulder just here. So these are two ways you can do it. If the patient is capable of externally rotating the shoulder and bending the arm, then of course you can do this with them. That's not a problem at all. But in some cases, if you've got a trauma, patient's fallen to an outstretched hand and you're suspecting a fracture of either the humerus itself, whether it's whether it's its distal or proximal ends or the shaft, or whether you've got dislocation. Patient may not be capable of both abduction and external rotation of the arm, so getting them to do it in the setup that I just showed you is a lot easier for you to be able to achieve. The great thing about this view as well is obviously the soft tissues. You can see the delts, you can see the triceps and biceps, you can see the forearm musculature, so this is very, very good for assessing those as well. So a little pearl to finish on: when you're going through the pediatric elbow, the order of ossification center maturity or maturation, okay, the acronym used is CRITO. Okay, so obviously the reason why is because the first one to form is the capitulum, then it's the radial head, then it's what they label as the internal epicondyle, which is obviously the medial epicondyle, then the trochlea, then the olecranon, then the external or lateral epicondyle. Okay, so CRITO is the acronym used to remember this. So I'm not going to go through age ranges with you just to confuse people and make it even more challenging and difficult, but this is the order at which they develop. So ultimately, if you know the age ranges of when these processes occur, you can take an elbow x-ray and you can roughly estimate how old the child is as well. So it's a very, very handy tool. And just to be very, very helpful, so we've got a nice annotated diagram just here. So we've got the capitulum, then it will be the radial head, then it's the medial epicondyle, then it's the trochlea, then it's the olecranon, and then it's the lateral epicondyle. So in this particular Pete's case, we've got all of the ossification centers are present and correct. So this is very, very helpful again of being able to identify whether or not there's an avulsion fracture. Most likely is going to be of the condyles, just to, for anyone coming up to exams, most likely areas of avulsion is going to be the medial and lateral epicondyles. So this is a very helpful diagram to get into your notes and burn into your brain as to the old CRITO acronym of ossification center order of maturation of the elbow. So as always, thank you very much for your attention. Feel free, and if you wouldn't mind liking and subscribing to the channel, it's always, like I say, it's always very, very helpful when people do that, because obviously it just helps to disseminate this information to more and more radiology geeks of the internet, and obviously students of radiology going forward. I think these series will be very, very helpful for any students going through radiology, so feel free to like and subscribe and share with your mates that are all going through their exams as well. And obviously next in the series is going to be the shoulder, and I'll get it up as soon as I can so that people who have got exams coming up in the new year, you've got an advantage over everyone who doesn't get to view these lovely videos. So yeah, all the best, and I look forward to seeing you all in the next one. Take care.